I will present a couple of data from all the Austrian centers, not only Klagenfurt, the city where I'm working, and also in Austria, like I would say in the majority of the countries, the stroke is one of the most common death causes, and actually the third one in Austria. That means that almost 90,000 patients per year in a population of about 9 million persons experience stroke every year, at least in the last 10 years. I would cite just a couple of milestones in the Austrian stroke history, I would say. One very, very important person is one colleague who was a neurologist, actually, and the past president of European as well as the World Stroke Organization. And he founded he founded the first stroke unit in Thames around 1997. As far as I remember or I know, I think that the very first one was in Germany, in Essen, in 1 year before, in 1996. And Professor Breinin opened the first stroke in Austria, stroke center. And then 1 year later, the Austrian Stroke Society was founded. And this was very important because since that time, a lot of colleagues, of course, not only interventionalists, but moreover neurologists, beginning try to optimize the treatment and the follow-up of these patients. In 2002, we got the first so-called Austrian Stroke Unit Register, and every year all the data were collected in this register, and it was very, very important to analyze data and to understand which kind of procedures or which kind of treatments for the patients had to be optimized in the country. Almost 10 years later, all these data were analyzed also to understand which parameters could be quality indicators and which one has to be considered important to create, let's say, some kind of regulations all over the country. In the city where I'm working now, Klagenfurt, for example, Professor Hausegger started doing the first thrombectomies in 2008 with the first 10 patients. Just to remember, 1 year before, the Solitaire as a dedicated stent retriever was launched, so we started quite soon, and all around the country, colleagues working in neurointervention tried exactly the same. But very important was 2015, after the publication of Mr. Clean study, because this kind of treatment was recognized from the Ministry of Health as a standard of care. Before 2015, I remember very well, there were a lot of struggles and discussions, especially with the colleagues from the neurology, because there were no clear rules, and also not everyone was convinced that it was a necessary therapeutic option. I would just cite some facts until 2018, collecting data from this Austrian Stroke Unit Register. I already mentioned the 90,000 strokes per year, and in 2018 we had more or less a onset to door time of about 2 hours in 50% of the patients. And unfortunately, we had for many, many years not really an optimization of this time, as you can see here. Since 2005, there was no improvement in this very important topic. In 2018, we got about 24% endovenous thrombolysis, increasing within a couple of years, but not that much. And even the mechanical thrombectomy was more than the double, so 4% instead 1.8, let's say, before Mr. Clean study, and it was quite clear to explain because of the fact that this kind of treatment was really recognized then as a standard of care. Of course, in the first phase, we experienced a lot of problems. It can be funny to read, but this is what we really experienced it every week, I would say, at the beginning. The patient that who arrived too late or with a very low blood pressure because the hypertension was treated in a brutal way at the very first phase. Sometimes patient kept intubated without reasons after our treatment, and all this stuff caused a lot of problems in the outcome in the first years. And sometimes very crazy things like patients transported in false hospitals, or even the false patient, and sometimes false clinical data, and was really a lack of time with the false site of the thrombectomy performed, let's say. This is how it looks right now since 2020. So this is the Austrian country, and as you can see, these blue spots are the stroke units. At the moment, there are 38 stroke units in Austria, and they have at least 2 beds, but the majority has between 4 and 6 beds in Austria. And if you consider that Austria looks like this, I would say, with high mountains, valleys, and as you can imagine, it's not always simple to connect very peripheral villages to main centers. It's quite clear to understand that the white areas that we can see here are those with more or less than 45 minutes time necessary to reach the hospital. On the other hand, the red areas are mostly like here, the Tauern or Alps and so on, are more difficult to be reached, and it's exactly the same, even considering the interventional units. In Austria, there are 12 centers, so-called neurointervention centers or comprehensive stroke centers, where we can offer 24/7 the mechanical thrombectomy. And of course, there is also a stroke unit in every center. Vienna is something special. Vienna has, with almost 2 million people around, and of course there are more than one center in Vienna, but nevertheless, even with primary stroke centers, we can reach the majority of this center within 60 minutes at the moment. And one of the reasons why it works in Austria is how the patient transportation is organized. And I think this is very, very interesting, and maybe it's an exception for many other countries in comparison to many countries, because the majority of transportation works with helicopters. There are 38 helicopters of different societies, and that means more or less 1 helicopter for every stroke unit. Of course, they have to transport also other kind of patients, but they are quite busy also with transportation of our stroke patients. About, let's say, mechanical thrombectomy, I wouldn't talk that much, but just to cite, to comment on a point that is, in my opinion, very important. This is how we started, for example, in our, or how it looked like, in our center in 2014. At that time, we had more or less only one single balloon guiding catheter. The 6-length teeth was used for posterior circulation. We had only 1 micro, 1 wire, and we used only the solitaire stent retriever. If we look at our portfolio last year, for example, and it increased even more, nowadays we have a lot of different materials. And of course, if we are considering an experienced colleague who started already, let's say, in 2008, he experienced new procedures and new skillness over these years. But we have also to think about the young colleagues who are starting right now, and they are not confronted with this situation like in 2014, but they have to learn a lot of new possibilities, techniques, and even how to deal with different materials and also different clinical situations. And for that reason, I think one of the most challenging things about intervention is the learning curve to really to deal with all this new stuff that we can offer to optimize the patient treatment. I think that everyone can agree that if we have to perform a simple aspiration is not comparable like if we would like to treat a very peripheral occlusion with quattro technique, for example. When we started, also our experience was in a very, very low state, and at the beginning it grew up over time, and I wouldn't go specifically about differences among the center, but more or less nowadays it looks quite similar in every stroke center in Austria. Mostly patients and the stroke is diagnosed with CT perfusion more than with MR. And most of the centers have two angio suites and at least one biplanar suite, but this is not a rule. There are also centers with only one angio cath lab. And for example, this is how it looks like in Provincia and in Klagenfurt, in our city. We have at least one interventional radiologist who can work together with two interventional technicians. That means also our technicians are part of the team, and they are working only in interventional radiology. And in our city, for example, we have 5 interventional radiologists and 18 interventional technicians, but this is, again, once more, it's very different all among the country, and there are, at the moment, no clear rules how many doctors or how many clinicians you should have at least to establish a stroke unit. I think it depends also on the resources that you can offer in every year and in every moment. So there are a lot of changes about this all over the country at the moment. But just to cite, I think that to build up a big team is a key point to get what I call the magic triple number. It took in our center almost 15 years, but we reached after 15 years a door-to-needle time of less than 60 minutes, or puncture to recanalization time in less than 60 minutes, and a TC score of 2B or 3 in more than 90% of the patients. And this is something special, I think, but it costs really a lot of energy for more than 10 years to reach this kind of result. And I think it's a situation that it's not well established. So it's very difficult to keep all the team in a let's say, in a good shape to obtain results like that. And there is still a lot of work to do to get the same result all over the country. How to do that? Well, in Austria, I think it's similar to many other states. The Ministry of Health try to analyze every year all the data that we collect, or moreover that our neurologists also collect, and try to optimize the lack in experience and to optimize also how we can teach new colleagues about this kind of procedures and how to deal with patients. In Austria at the moment, for example, there are 2 big groups that are recognized from law and so on to be able to do thrombectomies, and they have in the residency program also the possibility to get experience about that, and that means interventional radiologists, radiologists. In Austria, there is no clear distinction about these 2 groups, and also neurosurgeons. And at the moment, it's, let's say, majority are still radiologists, but there are more and more neurosurgeons that think to be involved in mechanical thrombectomy as well as radiologists. Comparing the data from the past, let's say, to those from 2023, we can say that at the moment we analyzed 89% of the whole amount of patients, so they are not the final data, but nevertheless, the onset to door time is for the first time better in comparison to the past, so it was reduced a little bit. The endovenous thrombolysis increased, not that much, and there are, I repeat, I can just present partial data, and the Ministry of Health is still analyzing that, but for 2023, we reached almost 6% of mechanical thrombectomy among all the patients admitted with ischemic stroke. That means there is still an increasing in comparison to 2015 and 2018, even if it's not that much. One of the big problems that we still have is that patients with large vessel occlusion, about 15% of those patients, are still admitted first in, let's say, peripheral stroke centers and not in the main center where we can offer also mechanical thrombectomy. And what I would like to show now is something that Austria is trying to do to improve also these numbers. It's a pilot, there's an ongoing test right now. It's the so-called Austrian Pre-Hospital Stroke Score. There are many publications about that already from 2021. And what our neurologists are trying to do is to simplify the way to recognize the so-called major stroke, mostly due to a large vessel occlusion, in order to let our colleagues, as a first aid, to discriminate between a clinical patient with a higher probability of large vessel occlusion to those with maybe minor or moderate stroke. Why it's important? Because according to this scale, we are trying to transfer the so-called clinical minor moderate stroke to the stroke unit with and in case with rip and shift to the mechanical thrombectomy in a main center. On the other hand, if, let's say, the pre-imaging clinical assessment shows already more than 4 points, and it's considered to be a major stroke, then we are trying to transfer the patient in a mothership model directly to the neurointerventional center in order to be faster to offer mechanical thrombectomy. And this new strategy is, I would say, connected with the improvement in the artificial intelligence. And one of the most used tools right now is the rapid artificial intelligence software. I'm sure every one of you knows that, and there are colleagues already using it. And this kind of software is integrated in a regional network platform, trying to improve all the flow in diagnostic, transfer, and treatment of these patients. And I think in Austria, there's one region that is very, very advanced in that. Professor Deutschmann in Graz, in the whole city, they used for the first time the most extreme version of this software. And they created, like more or less in Cairo, and now we are trying in Valencia, they created a so-called regional network connecting all the hospitals in the region, not only the main clinical centers, in order to optimize the diagnostic, transfer, and treatment of the patient. It's still an ongoing program, of course. In Styria, it is working excellent right now. Also in Tyrol, they organize something like that, and more or less in every other region in Austria, we are trying to optimize all the treatment of stroke patients with, let's say, high-end regional networks. Very important is just not only the treatment of patients, but with stroke, it's crucial also the rehabilitation of our patients, and this is also something that will be optimized right now. In Austria, there are already 20 rehabilitation centers, and the Ministry of Health is trying to set also in this case, so the post-treatment stroke, trying to set standards of care and regulamentations to offer the best rehabilitation that we can obtain for this kind of patients. I thank you for the attention. I know that my presentation was not maybe so technically detailed like the thought we had before. It was just a showcase of another country, I would say. And last seconds, this is Klagenfurt here with the Wörthersee. And if you have time and interest in about 1 month, it will be held here in Pizza. One of the most interesting meeting from CIRSE, the ICCIR, about how to handle complications, also in neuro interventions. And I repeat, if you have time and interest, I would invite there where Professor Hausecker and Professor Wolf have organized a beautiful meeting. Thank you.